Welcome to the Medical Independent Innovation in Healthcare podcast series, where we explore the advances that are transforming Irish healthcare and the innovative minds behind them. From cutting-edge technologies to groundbreaking research to new models of care, Ireland is at the forefront of medical innovation. Our guests are leading figures in the Irish and international healthcare community who are revolutionising the way patients are being treated. So whether you're a healthcare professional, a patient, or simply curious about the latest developments in Irish medicine, join us for an engaging and informative discussion.
Hello and welcome to the latest episode of the Medical Independent Innovation in Healthcare podcast series. I'm your host, Priscilla Lynch, Clinical Editor of the Medical Independent and International Centre for Journalism Health Innovation Journalism Fellow. Joining me in this episode to discuss innovation in vaccination is Professor Sam McConkey, Head of the Department of International Health and Tropical Medicine at the RCSI University of Medicine and Health Sciences, Dublin. He is also a consultant in general medicine, tropical medicine and infectious diseases at Beaumont Hospital, Dublin and Our Lady of Lourdes Hospital, Drogheda, both in Ireland. Last November, Professor McConkey was appointed as Chair of the Board of the European Vaccine Initiative, a leading European non-profit partnership that supports global efforts to develop effective and affordable vaccines against infectious diseases that disproportionately affect low and middle income countries. Firstly, Sam, can you tell me a bit about why you were attracted to the area of vaccination as a key focus of your career?
Well, thank you. Thanks, Priscilla, for inviting me. Why did I get attracted to vaccination as a research focus for my career for probably about 30 years? There have been several amazing sort of successes of vaccination in the past. Obviously, most people have heard of the smallpox elimination, which is just the idea of eliminating a disease and most of a pathogen from the world is obviously a great goal and a great success, coordinated by WHO and lots of people working together. I worked as a student in Sierra Leone, seeing many pregnant women and babies who were born who had a disease called neonatal tetanus, where there was contamination of their umbilical cord with essentially feces and muck and materials that cause tetanus in those babies. And day 7 to day 10, they get clonic muscles, can't suckle, clonic abdomen, and universally pass away. That was 1986 and 87. Then I was back in Sierra Leone in 1993, where I worked for several years as a doctor and as medical superintendent of a mission hospital. And by that time, neonatal tetanus had disappeared. Why? Because the government had implemented a neonatal, a maternity service vaccination with tetanus vaccine for all the pregnant women. So at booking, all the women got to get their tetanus vaccine, and that antibodies transmit from mother to child, and then the children no longer got it in ways that are just wonderful. The mothers protected their babies from tetanus by having this vaccination, and essentially got rid of that clinical syndrome of these 7 to 10-day-old neonates who couldn't feed. And there are many, many others, whether it's polio or lots of other. So the transformative potential of vaccination for human health has been demonstrated repeatedly. And again, of course, the most recent one on our minds is the new mRNA vaccines against COVID-19 that, as we heard, were 94% effective. That's better than I'd expected it. If they were 70 or 80, we'd have been happy, but they were actually better. And that really meant that death and disease from SARS-CoV-2 dropped dramatically. So we still have SARS-CoV-2 floating around the world, and it will continue to float around, but we're not seeing the death and disease. Part of it, of course, is naturally acquired immunity from having it before, but a big part of the reason why we're now healthy is because many of us got those mRNA vaccines. So vaccination as a tool continues to excite me and to sort of offer up really innovative, novel, effective, safe solutions to these horrible diseases.
You were quite involved actually in Ireland in relation to the rollout of the COVID-19 vaccine, but it's such an exciting development. I think that really put a vaccination innovation on the world spotlight, didn't it? That we could create vaccines that were effective and safe in such a short time period for one disease.
I really said there were 3 ways to address this SARS-CoV-2 COVID-19 problem. One is the vaccine, but I said at the time that will take 3 to 7 years, famously, because animal vaccines typically did have a 3-year development cycle. And of course, human vaccines typically were in a 7-year minimum development cycle. So that was just based on past performance. Obviously, with the multiple billions of multiple investors going into many, many drug companies, we did it in a year, and we had several good products within a year. So that was exceeded expectations again. So that was a an unprecedented thing. So that COVID thing was a sort of once-off experience that I'm hoping it won't come back in the same way. It'll be different next time.
But we did learn some really valuable lessons in the vaccination sphere from COVID. We had more than one vaccine technology. But you mentioned there about the mRNA vaccines. That's a very exciting area. COVID obviously springboarded them into a very effective vaccine, and they're being looked at across a range of other disease areas, which is very exciting because that particular technology is very scalable and really applicable to lots of other diseases.
Yeah, I completely agree with that. And I would sort of provocatively say with some hope that maybe diseases like melanoma and some cancers where there's even some other skin cancers where there's evidence of immune system control of those cancers. Those cancers are much more prevalent in people, for example, with a transplant or with HIV. So we know that a good immune system helps to protect you from those. So we hope that vaccination may well spread into areas that people wouldn't immediately think as to a disease susceptible to vaccine. But I'm hopeful and optimistic that might happen. And then the second area is hopefully autoimmune disease, that we may be able to look at vaccination against completely different sort of ideas that we've really never thought about before. So I'm very excited about that diversity. And of course, malaria, as we'll come on to talk about, is this sort of complex, very large pathogen, a sort of eukaryote. And it's one of the first real protozoa eukaryotes that we've had a good vaccine against. So again, this mRNA gives us hope that other diseases, whether leishmaniasis, visceral leishmaniasis, another huge problem in places like southern Sudan and many relatively poor countries, and effective vaccine against other protozoa eukaryotes has eluded us so far. But I'm hoping the mRNA vaccines will also offer that technology available to us in the future. So I think it's very exciting. So there's huge investment at present to explore those possibilities, which I find very, very exciting.
We really do seem to be in a golden age of vaccination innovation at the moment. There, as you've mentioned there is a lot of interest. There's a lot of hope and excitement with these new platforms about the ability to create better, more durable vaccines. So it really is very interesting. And I suppose, as you've just mentioned there, into healthcare areas that we wouldn't have imagined that we could get vaccines for. The HPV vaccine was obviously a major breakthrough. It's proved to be very effective and is in widespread use across the world. But as you've said, there are other cancers that will be potentially able for that. And multiple sclerosis as well is one of the new areas that researchers are looking at that could be preventable as well by vaccination from the Epstein-Barr vaccine. So that's really exciting.
I worked for several years on a hepatitis B vaccine, the first anti-cancer vaccine before the human papillomavirus one. So for many parts of sub-Saharan Africa, in particular, where I worked in both Gambia and Sierra Leone, hepatocellular carcinoma is the most frequent cause of death from cancer in men. And thankfully, in Gambia, there was a hepatitis B vaccination at national level of teenagers that started in approximately 1985, 86, 87 in what's called a step wedge design all over the country of Gambia and West Africa. Then I was involved in a 15 to 20 year follow-up to look and see what were the medium and long-term benefits of that vaccine. Of course, they were fantastic. We also looked at whether a booster was needed. Turned out you probably don't need a booster if you've had the full 3 doses. So hepatitis B vaccine has been widely used in Asia and in sub-Saharan Africa, and is really particularly good anti-cancer vaccine, particularly for men. The human papillomavirus vaccine that you mentioned obviously is the most common cause of death from cancer in women in sub-Saharan Africa. So it also offers a big benefit. The sad thing there, which I think is a real theme that I would like to emphasize in this podcast, is that access to care and getting the vaccines to the people who really benefit from them has not been particularly good in the past. That our healthcare systems often don't match the needs, people who can need and benefit from a medicinal product to the supply and to the delivery of it. That's a feature of many, many healthcare systems, that the matching nature of supply and demand is largely dysfunctional. In general, to be a bit provocative, you just leave it to market forces. It really doesn't work at all well. The reason is that many of the people who benefit most from these technologies have the least ability to pay for them themselves as individuals. So we need some sort of risk sharing, some sort of financing systems at national level and regional level that help to make sure that the products that can really help, particularly very poor people, actually are able to get to them, and that people aren't really sort of dying in a really wealthy country for diseases that are potentially treatable or preventable if we had a healthcare financing system that was actually fit for purpose and supplied the products and the technologies and the screening to the people who would benefit most from it. So that issue of access to healthcare is very large. It's not actually only vaccines. It actually applies to lots of other healthcare technology. It's universal among healthcare. There's a wonderful phrase called the Tudor-Hart inverse care law. This Tudor-Hart was a GP in Wales, and he wrote a bit in the Lancet in the 1960s, saying that there was an inverse relationship between people's ability to access healthcare and their need for it. That the people who need it most have the least access, and the people who need it least have the most access. So that it's called Tudor-Hart's inverse care law, which sounds like some sort of law of physics, but it's really a sociological phenomenon, which when you investigate it at national or local level, it turns out to be almost universally true. There are almost no instances in the world of communities where it doesn't turn out to be true. So I would challenge anyone to disprove it. So this issue of lack of access to healthcare, to me, is one of the big themes of our time for health. If we could just provide the access to care for the 8 billion people in the world to those who need it, to provide the right service to those who need it, we'd get a big boost in improvement in health outcomes. I mean, that includes things like TB cessation and good care of obesity.
Absolutely. And healthcare inequality has been a theme, I think, in this whole podcast series, that innovation is fantastic, but actually getting access to that innovation in healthcare is the most important thing, really. And for so many countries and so many populations, that is very difficult. On a recent trip to South Africa, I really saw firsthand inequality in access to healthcare over there. But I suppose as well, from researching the Global South and the African continent, the real difference that access to vaccines can make in these populations, as you even mentioned there earlier in your career. And now I think we're looking at malaria in particular. Obviously, you have the big organizations like the World Health Organization, Gavi, the Vaccine Alliance, and UNICEF working together to make sure that people do get access to these vaccines, because it has been a huge breakthrough. We have 2 effective vaccines against malaria, and they're the first generation vaccines against malaria. And they're really important because they're the first against the human parasite. And there's been over 50 years of research in trying to get these vaccines. So when we compare it to COVID-19, where we're able to get a vaccine up and running, I know it's a much simpler disease in comparison, but it really is an amazing breakthrough. And I don't think really we have that appreciation for what an achievement it has been to create those 2 vaccines. And also now that the job is to get them rolled out in Africa, and we've started doing that, but they have to be affordable, they have to be scalable, and they're also multi-dose vaccines, which makes it trickier to make sure that we do get that coverage and that uptake among really the youngest population, under 5s, infants, who are most impacted by malaria, because there's over 500,000 deaths still annually globally, the majority in Africa, from malaria in under 5s.
Yeah, I agree with that. European scientists had a huge role in both the RTSS and the R21 vaccine. The RTSS was largely pulled together by folk in GSK, which is Rixensart in Belgium, obviously with a lot of funding from the US and from all around the world. And then the R21 is again a large consortium, including people from West African countries and folk from the Oxford group have developed that. Both of them have worked really well to help prevent death from malaria in developing countries. So I think that's a big step forward. And I'm delighted that they're licensed. I'm delighted that there's a plan to actually roll them out. With my hat on as chair of the board of the European Vaccine Initiative, of course, I'm delighted because the phase 1 studies for the R21 were actually sort of a consortium brought together by the European Vaccine Initiative. And we've actually been involved with the phase 2 and phase 3 through the European Union Developing Countries Clinical Trial Partnership, EDCTP. So there's been a lot of European public funds from the EU and a lot of EVI funds, and it's building these research support that show that the R21 actually works. These are very much the products of, I would say, consortia. And I know it's hard for maybe the listeners to see that people think of the scientist as sort of crazy individual who does it all, but in fact, an awful lot of it's done in team working. It's probably not that much different from building a large computer software program. You actually can't do it one person on their own. And similarly, that's how this science has moved forward. So really the challenge is to help groups of maybe 50, 60, 70, 80 people to actually work together in a cooperative way for often 2, 3, 5 years on a shared goal, a shared vision, and to bring in the funding and the sort of ideas that sustain that. So there are team leaders and team builders, and certainly Odile Leroy and Nicola Wiebig were the two folk from EVI that were working on R21 for many, many years, and very, very committed to a vaccine that would work. Not so much a sort of a vaccine for travellers who are kind of wealthy and going on holidays to somewhere and worried about getting malaria, but rather a vaccine where the mortality and morbidity of malaria is manifest, which is, as you said, small children under 5 in sub-Saharan Africa. There's between half a million and 600,000 children each year have been dying from that since 2016. The numbers did improve about 10 to 12 years ago, but largely because of bed nets, and the Global Fund had an integrated malaria control program. But then they plateaued off at about 600,000 deaths a year in 2016 and have remained fairly steady. So it's been a very intractable problem. The challenges, of course, are how do you deliver a multi-injection vaccination program to rural parts of Democratic Republic of Congo, or ex-Zaire? There are many, Eastern Zaire is just, it's a conflict. There's intra-Hamwe, there's basically a grumbling civil war actually going on there that we don't talk about very much, we don't hear about very much, but trying to deliver a health program for, every small baby under 5 to get multiple vaccinations for malaria in that context is really, really, really challenging logistically. So that is the challenge now, is how to roll those out. It's relatively easy in many other countries, especially urban ones where there's more of a health infrastructure. But when there's grumbling war and displaced people, even if you take Darfur or Northern Sudan, or particularly Southern Sudan, again, where there's essentially grumbling war and, very high level of people being displaced and killed, it's a challenge. So it's back to the access to care issue. How do we get access for the people who need these vaccines to them?
Absolutely. And as you mentioned there, that there is a strong focus in Europe on trying to make these vaccines for neglected diseases in countries such as sub-Saharan Africa, and that there has been a real impact there. But it's the logistics again involved. There is further work being carried out in Europe actually, and other countries as well, looking at creating single dose vaccines, perhaps with new technologies, thermostable mRNA technology, new adjuvants, novel virus-like particles, all very scientific, looking at creating better vaccines, and that can be given easier, as you said there, because even though we might have a new vaccine for malaria, 2 of them actually, which is fantastic, how do we make them easier to access and easier to administer and to deliver to these countries, and hopefully as well vaccines that don't have to be stored at particular temperatures in certain ways. So isn't that all really part of it as well? Just that not only what works in the lab and what can obviously fight the disease, but how do we make it easier and more stable? And so that's really, isn't it, still a tricky question?
So there is a lot of work in optimizing and improving. And unfortunately, I've done lots of sort of vaccine research trials as principal investigator, and sadly, a lot of them don't work. There's quite a lot of legacy of vaccines that it was a good idea at the time. It maybe worked in mice, but when you try it in humans, it doesn't work. And that's okay. You still have to try out and show what doesn't work. That's really the only way to move forward. So those, in my view, each one has to be systematically evaluated. And the 2 big questions the regulators want to know are, 1, is it safe? And 2, does it work? And you have to demonstrate that through empirical evidence. So there's quite a long road of data collection and research and systematic evaluation to improve those. But I'm pleased with where we're at. Other things that EVI is doing, we're looking at things like Salmonella typhi vaccine, Leishmania vaccine. So initially, European Vaccine Initiative evolved out of a European malaria vaccine initiative, very focused on malaria. But in the last 5 years or so, we've really looking much broader at other diseases that are associated with developing countries, where maybe the big pharma don't always necessarily want to invest their shareholders' funds in doing the high-risk studies, highly innovative, highly novel phase 1 and phase 2 clinical trials in humans, where maybe there's something like a 70 or 80% chance that product will never become a marketable item. The companies aren't interested in that. So the EVI has been filling that niche and saying these diseases are important. There are people who are suffering from potentially preventable, whether it's diarrhea or typhoid or leishmania or malaria, and funding and creating the consortiums and the financial backing for these diseases that are important on a worldwide level, but not necessarily in a high value market like Ireland, where people maybe don't worry personally about getting malaria. So EVI has a very clear niche now, not just in malaria, but in other diseases. We're also working recently with the tuberculosis vaccine initiative, TBVI, and we're working increasingly closely with them, which is great. So we're comfortable working with others, we're comfortable working consortia and finding social and legal ways of binding ourselves contractually to others that are effective in delivering predictable results to all the parties. We are quite responsible and very deliberately so to make sure that the money that EVI raises is actually spent on appropriate research to deliver what our goals are, which is to develop new products for diseases that are important in developing countries where there perhaps isn't a big industry interest in doing that.
Absolutely, because mosquito-borne diseases pose a very significant threat to global public health, largely in sub-Saharan Africa and other regions, and they affect millions of people annually, but I suppose we don't hear that much of it over here. Scientists obviously do, but developing vaccines for mosquito-borne diseases, it's very challenging due to the biological complexity of these pathogens, but obviously the malaria vaccines have been a major breakthrough, and also in other mosquito-borne diseases such as dengue, there's vaccines, there is chikungunya, and also I'm sorry, my pronunciation isn't fantastic there for that. And while we don't have a licensed vaccine yet for Zika, we are well on the road there, and there have been candidates that have been trialed. So there has been major progress in these particular diseases, and that's largely thanks to very important work being carried out by collaborations, by institutions, and working together.
I'm very optimistic about a Zika vaccine for a number of reasons. One, the outbreak of microcephaly, as it's called in small babies, small brains in Brazil a few years ago, was just almost the stuff of nightmares. If you were to come up with a sort of a fantasy fiction of some horrible disease that would affect humanity, you could hardly dream up a more nightmarish scenario. And then the mosquitoes then spread quite widely up through Central America, spread into Florida, and there were cases actually in many of the Caribbean islands and in Florida as well. So despite the sort of, what would you say, wealth and might of the Florida tourist industry, which is colossal, they were unable to prevent the transmission of Zika in Florida. So really, killing the mosquitoes was never going to work. So really, we need a different plan, and that's a Zika vaccine. And that's really where people are going. And it's a fairly stable sort of RNA viruses. I'm reasonably optimistic from sort of theoretical perspective that we will end up with a safe and effective vaccine against Zika. It's still circulating around, parts of Southeast Asia, so it hasn't gone away, and it's likely to come and go in waves again. It's an absolutely horrible disease, and as you said, I think there's a good chance of a vaccine.
Again, getting them through the approval process and then actually rolling them out to the populations that need them. And with climate change, mosquito patterns are changing as well. And in Europe, we feel very insulated against that, but actually that's not necessarily the case as we go forward. And we are getting more cases of diseases in Europe that we wouldn't have seen before, particularly in relation to mosquitoes. So again, that's something to be very conscious of. And I suppose the timing is very good with these emerging vaccines for those particular diseases.
I think that feeling of being sort of far away is particularly the case in Ireland, where we're sort of a small, coolish, stable climate island in the North Atlantic somewhere. But clearly, it's quite different climate change in southern Greece, where there's wildfires, or Italy, or Spain and Portugal, where there's certainly a huge problem with excessive warming. And, there are now more of these mosquito-borne arboviruses, as we call them. Arboviruses, it's not a class of virus biologically, it's just the viruses that are transmitted by mosquitoes. And there's certainly many more of those now than there were 20, 30 years ago in southern Europe. But it certainly changed changed how we see our holidays in the sun, that it's just too hot, and there are risks of diseases we never would have thought about.
Looking at cooler climates, including Ireland, one particular disease that has caused a lot of problems over the years and has seen really not so much a re-emergence, but just really an escalation in the last couple of years has been RSV. So we've seen huge numbers of hospitalizations of young children, particularly under fives, in the winter in Ireland, the UK, other parts of Europe and other countries as well, such as the US. That area, again, we have seen a very welcome innovation that we now have vaccines for infants with RSV and also for older adults. So if you could maybe tell me a bit about the potential impact, obviously, of the RSV vaccines.
RSV has been there for hundreds of years, if you like, and certainly decades. So that winter surge of small children with bronchiolitis was a feature in Ireland up until 2020. Then with COVID, with the social distancing and COVID, it went away for a few years, and then it came back with a vengeance after everything opened up. So we certainly had huge winter epidemics of sick children with a mixture of influenza, some COVID, and RSV all together. And that was overwhelming, I would say, for some of the pediatric hospitals. When children need oxygen, they can't go home, they really need a lot of support for a few days. And for some, it can be fatal and certainly very distressing, because small babies under a year who are really almost presenting like with severe asthma, can't breathe, and distress and visual distress, and struggling to get enough oxygen into their body. So I'm really delighted that there are good products that will address these. I think for older adults, there are several others. There's a new shingles vaccine that prevents the reactivation of varicella zoster vaccine. It seems to work reasonably well. The shingles, you may say it doesn't kill anyone mostly, but occasionally it does for shingles encephalitis or VZV encephalitis. But it certainly is a lot of pain and a lot of destruction. If you take the sort of amount of sort of creative brain loss from all that people take for the pain, it probably does impact on our lives quite substantially. So the morbidity associated with shingles is quite considerable. And having a good shingles vaccine for the elderly, I think, is wonderful. Thirdly, I'd encourage that pneumococcal vaccine, conjugated polyvalent pneumococcal vaccines out there. And again, I would encourage everyone over sort of 65 or people with chronic heart and lung disease to be going for that. And then, of course, the flu vaccine, which has been around. I'll not say it's not 100% effective. It's partially effective, but that partial effectiveness is worth taking. Certainly all of us as healthcare workers have it regularly, and I would encourage all of the listeners to have it themselves if they're in the categories, and to recommend it for more people. In the US, it's a much wider recommendation, more or less recommended for everyone, and there's now an influenza vaccine, a live one, for children and younger people as well. So I see it becoming more of a universal approach to preventing influenza rather than just sort of ticking target groups. There's a research theme of looking for what's called a universal influenza vaccine. That's one that doesn't change from year to year. So the influenza changes its genome every year a little bit, and drifts and shifts and jumps, and you have to get a new vaccine to prevent the new strain each year. So there's a hope to find a vaccine against the protein components that doesn't shift every year. That's an active research thing, and I hope that works. I've yet to see the evidence that it definitely does, but I'm waiting with optimism.
It's very interesting you brought up that topic, actually, because I was going to ask you a bit more about that. For World Immunisation Week earlier this year, I visited Belgium and I saw one of the world's biggest vaccination plants, which was a really interesting journey. But also there was a lot of talks about vaccination of older adults. And as you mentioned there, shingles, pneumococcal vaccine, flu, COVID-19 vaccine. And there has been a lot of developments in that area, but it's also as well about what we can do with our health systems, which are overburdened, and how do we reduce the burden on our health systems. Whether it's among our youngest population who get the most vaccines, and then also our older population as well, and looking at that and obviously trying to balance the costs, the economic benefits, the healthcare benefits there. So there's a lot going on in that field, but it's very welcome that we do have that choice now, that there is RSV vaccines for older adults that are just coming on stream now as well, that there is the shingles vaccine as well. And now we're looking at the chickenpox vaccine in Ireland as well. And obviously our vaccination schedules do change with the times, do change with the impact of disease and with vaccine innovation. So there's always something really interesting going on there. We've talked a lot about major breakthroughs here and huge successes, but we have to acknowledge as well that a lot of vaccine candidates fall at the first or the second hurdle. Like I would get a lot of press releases about early stage clinical trials, laboratory trials that sound very promising, but they don't just get over the line. Safety has to come first, and then efficacy. So there's an awful lot of work. The current vaccines are standing on the shoulders of a lot of those who failed beforehand. And there are other diseases where we haven't quite gotten there yet. So there are lots of elements to consider.
Yeah. So this is really the way that science and technology developments work. And, we're in a very wonderful time to be alive when we have this science and technology and understanding of the biology of ourselves and the world around us, and the pathogens, and of the immune system, and of the molecules and cells that mediate that we're able to actually try and make our lives better. The interesting with malaria is that to get natural immunity to malaria, it seems if you need the bite of not just dozens, but even hundreds or maybe even 1,000 infectious malaria mosquitoes. So naturally acquired immunity to malaria takes many years and perhaps 1,000 bites. Whereas we're hoping now, as you said earlier, to maybe have a small dose, 1 or 2 doses of a malaria vaccine that would actually do better than natural immunity. So what we're trying to do here and what we're proposing is something quite audacious and quite challenging, and yet good for human health. So really wonderful. So I celebrate that. And I suppose I see it, the world of vaccines, as not so much different from other aspects of the world. And the question then is, do we have political commitment and funders' commitment to really invest in these consortia that really require billions to actually develop a significant new product worldwide? And clearly we saw with COVID, we did have that political commitment, and we did have several billions of euros quickly to make it happen. But for the other things that we've talked about that aren't there yet, do we have the commitment for 10 or 20 billion euros and sustained political commitment over many years to put a team of people together, which is dozens, maybe even hundreds of people to work together on developing it? So it is about a commitment to the coordinated activity of fairly large groups of human beings that's required to build this. It's about putting together a team of people who've got complementary skills and the ability to work in a sustained way on a common vision, and the funding to sustain that and motivate those people over several years or decades to achieve it. So I fear that, in some countries, there's sort of almost what I would call an anti-science movement happening in senior government, and people are saying and reacting against the idea of spending public money on these teams of people to solve the new complex problems we face. And I worry a lot about that. That's a proper problem. If that happens, then the sort of successes we've been talking about won't continue. So we really do need to do what we can to lead and to share with the 5.2 million people in Ireland and people around Europe and around the world, that with the cooperative activity of large groups of people and sustained funding, we can actually find technical solutions to these rather thorny, complex problems, whether it's in healthcare or whether it's in global warming. If we get cynical or hopeless or whatever and just give up trying, then of course we won't get solutions. But with sustained funding and large groups of people working together, I really strongly believe we do. So I think there's quite a lot of political messaging needed for us as scientists, for the journalists to tell the story. So it really an essential part of the solution are the storytellers, the journalists who share the stories. And ultimately, it really has to be folk with a lot of wealth and sustained political commitment to get these things done. Without the the primacy of politics, the primacy of political power to lead us and to lead the funding and the team development, then science doesn't work on its own. Without that community support, we require money, we require sustained commitment from the community to make science happen. So it isn't like the artists sort of out on their own in their cottage doing a little picture. It's a big team of people and requires several years to develop them. That's separate from the anti-vaccine. This is just almost an anti-science, anti-empiricist kind of almost sense of sort of voluntary hopelessness. It's almost sort of saying we're not going to try and address those problems. We want, I don't know whether it's a sense of fear of corruption or fear of money being misspent or fear of power changes or fear of the future. So there's lots of inhibitory factors that I think are really working against us here. And I don't know how that's going to play out really, but I think that's a key issue, particularly for Europe and America, where we have thankfully very open communicative political structures. There's a lot of to and forth and back and forth of different points of view. So I think there's a real need at this time to present the benefits of what science can potentially do for humanity and make it better.
You're right. It really is part of a jigsaw, isn't it? And we all have a role to play, but trust is absolutely essential there. And we are living in a time where trust is being eroded in science and in our ability to solve problems and also in existing solutions. You mentioned their hesitancy, and that is a big issue now, really, isn't it? In vaccination, we talked about all these really exciting innovations and these new vaccines that are coming on stream, the challenges to get them rolled out. But we're looking at diseases like polio that hasn't quite been eradicated and does pop up, and measles in particular now in Europe because of inadequate vaccination levels. So it's a continuous battle really, isn't it there? But just to engender that trust and to show that data, as you've said, that we have to be absolutely transparent and forthright with people. But again, we have these solutions. They do work. They are effective. But as you said, we seem to be nearly in a post-information time when there is that cynicism. So for people like yourselves, it really is important that your voices are out there and that you are communicating and that the scientists do get out there to say, well, this is what we're doing, this is why we're doing it, and it works.
Yeah, I obviously, as you said, thousands and thousands of media pieces over the last 4 years with COVID and several others as well doing it. There was a certain amount of hostility. I remember being asked sort of live in air, somebody said, how do you feel when somebody's, giving out to you about what you're doing or really making personal attacks rather than actually discussing the themes and topics you're trying to talk about. They're personally attacking you because you're the messenger. I sort of said, well, I feel happy about that because at least it means I'm engaging them. We're actually having a discussion, and it means I've said something that has resonated with them, if only in a bad way. But it seems to me then we have to challenge folk who are questioning science as to what is the real alternative? What is the sort of utopia that they're hoping to create? What sort of future do they want for themselves, for their children, for my children, your children? What are they aiming for, and how are they going to achieve it? So I think there's a real need to actually present and challenge folk who are criticism of science or these type of science-based public policies to what's the alternative. And so it is helpful to reflect that this idea of political polarization is not just a new thing, and personalized attacks on others isn't a new thing. That's been the world that our ancestors lived in. And personal credibility is important, in my view, for maintenance and of trust and promotion of trust and for carrying out public policy and political power. So, I mean, I think the intersection between politics and science is really critical. And I think many of us in medicine science aren't really putting enough effort and focus into that. We need to bring the whole community with us and explain why is it good that, some public agency should give me a couple of million euros to do a hepatitis B therapeutic vaccine. Why is that money well spent? And we actually have to make that case and explain why it is well spent, that maybe there's a 10% chance that you'd actually find a cure for hepatitis B, and that's a cause of hepatocellular carcinoma, which is one of the biggest causes of death of cancer in men in West Africa. And of course, it's a cause of cancer death in men in Ireland as well. So a therapeutic vaccine for hepatitis B is truly a worthwhile thing to spend money on. And if that individual product works, that's great. If at 90% chance it doesn't, that's still okay. You still spent your money well, showing that particular product perhaps didn't work, and you have to change it in some way to make it work. So I think that idea of advocating for science is really an essential role, and I suppose that's part of my role in RCSI and in the European Vaccine Initiative, which I sort of try to do when I get the opportunities.
You're an excellent science communicator, and I've heard you many times on radio just calmly explaining the science, and I think that's, as we've said, we need more of that, really, because in the face of misinformation and political apathy and other challenges there, we do need those reminders. And that brings me really to my final question. In your career, looking at all these different vaccine technologies and developments, what's been the most exciting breakthrough? And I suppose, what would you like to see happen? What's the other area that you'd really like to see advancement in?
So I was a clinical investigator in Oxford in 1999, 2000, 2001, 2003, and I worked there giving new types of vaccines, DNA vaccines that were based in plasmids with a boost from a modified vaccinia virus anchor, or MVA vectored vaccine, which is sort of a precursor of the adenoviral vector, in a sequence called prime boost. We prime with DNA and boost with either fowlpox or MVA vaccine, booster vaccine. They were for both melanoma and hepatitis B and for malaria, so we had multiple pathogens going. And the malaria program was the furthest ahead, and we were trying to generate vaccine-induced T cells, CD4 and CD8 T cells. So most of the vaccines up to now really generate very good antibodies, and that's one arm of the immunity called humoral immunity. There's another one called cellular immunity. We actually showed in a paper and published it from malaria vaccines that using these prime boost technology of a DNA vaccine followed by MVA, we could generate T cells that were specific against malaria peptides. And that was one of the first really times that people had shown confidently that we can make T cells that are specifically directed against specific protein antigens. And T cells are so powerful, they kill off your cancer cells. They kill off loads of cells. T cells are the mediators of rheumatoid arthritis and lupus and lots of other things. So if you can actually control and influence what your T cells do, using artificial vaccines, that's a really powerful thing. And that was fantastic. We got it into Nature, so it became a Nature medicine papers, and that was published about, I don't know, 2004 or something. So of my own sort of work that I did with my own hands, if you like, that was it. Probably I was there writing the protocol for the study and designing it, and also then giving the vaccines to volunteers, taking the blood, and then I'm good at playing with T cells, so I can do ELISpots, I can do the lab work as well. So I did it all with my own hands, if you like. pandemic. So that was very, very exciting. And that legacy of being able to change T cells actions and to stimulate them against specific antigens, I think has huge potential. And the mRNA are trying to do that as well. So I'm hoping that they succeed in that too. So having said that, I'll say honestly, I did have lots of ones that I tried that didn't work as well. So that's okay. It's very easy to have something that works in a mouse or, in a laboratory animal, but then you can try it in humans. It just does no immunogenicity, no real efficacy. So it's I don't have any problems saying that out loud. I think that's essential. Unless people go through loads of experiments that don't work, you're not going to get the one that does work. So I've done lots of clinical trials that showed things didn't work as well.
That is very important, because I don't think that message does get across really, how much work went into maybe making this successful vaccine candidate, that how many eggs did you have to break first to get there. And I do think it would be actually good to get that message out a bit more widely so that people could see that. And I think that helps engender trust as well, that this just didn't magic itself up, that there was an awful lot of steps involved. I think that is literally just the final thing. What area in vaccination do you think we're going to see maybe the next biggest breakthrough in, or that you'd like to see the next biggest breakthrough in?
And that's a wonderful question. Thanks. I think it's probably, as I mentioned earlier, the hope that some of the messenger RNA products can have an impact against melanoma and maybe some other cancers. I think that's technically theoretically likely or possible, and it's just a matter of getting the right one and showing that it works. So malignant melanoma is such a horrible skin disease. It metastasizes into really absolutely horrible disease. An idea that we could vaccinate as a therapeutic vaccine for it or a preventive vaccine with these mRNA vaccines would be wonderful. It almost that gives people a completely different idea of vaccines. They're not just against infections, they're actually against a malignant skin cancer, and that would be just wonderful.
And that is all we have time for. Thank you very much, Professor McConkey, for joining me in this special episode on innovation in vaccination as part of my International Centre for Journalism Fellowship in Health Innovation. This project was funded by the ICFJ through the Health Innovation Call. Please tune in for further episodes of the Innovation in Healthcare podcast series.
That brings us to the end of this episode. Thank you for tuning in. Please subscribe to The Medical Independent for the latest healthcare news and debate. Sign up at www.mindo.ie to stay up to date on all the latest medical news. Join the discussion on Twitter at med_Indo News. Introducing the new Medical Independent app. Why not join over 14,000 healthcare professionals and stay up to date on the latest healthcare news in Ireland? Read in-depth reports on the issues impacting the health service and medical professionals. Trusted insights, breaking news alerts, in-depth analysis, and more. Download the Medical Independent app on the Apple Store or the Google Play Store by searching the word Mindo. The Medical Independent app. Your news, your way.